investigators. It's the level of medicine in Mexico is very high. So I'm going to start by showing you the slide that describes everything. It tells you the answer before I even give you the answer. And now we think that IBS is started by food poisoning or gastroenteritis. We think a toxin from the gastroenteritis is precipitating an autoimmunity that then leads to a neuropathy of the gut, and that neuropathy leads to bacterial accumulation called bacterial overgrowth, and that's why IBS is an antibiotic-responsive disease. So let me take you through this a bit step by step, but I'm going to do the first part very quickly because you've seen some of this before, the association between bacterial overgrowth and IBS. I'll first start with non-constipation IBS. We now know based on breath testing and the meta-analysis using age and gender-matched controls that breath testing suggests that there's malfermentation or abnormal fermentation in IBS patients as compared to healthy controls. But this implied that there was bacterial overgrowth because breath testing is used for bacterial overgrowth diagnosis. Critics said, well, what about culture? We need to know by culture or by more molecular techniques. And now these have been completed. So now there is proof that even by culture, this is a study from Sweden by Iris Posserud, and what she showed that in IBS patients, there was too much coliform bacteria in the small intestine as compared to healthy controls. Now, further studies have suggested that if you use criteria for defining bacterial overgrowth or accumulation in the small bowel, 60% of DIBS patients have bacterial accumulation in the small bowel. The control group here is not healthy people, but people who are undergoing endoscopy for another illness. So it's not healthy people, and still the difference is very remarkable. We now think there are 3 major bacteria. These are the first 2. E. coli and Klebsiella are higher. Now, it doesn't look very much different on this graph, but you have to remember the y-axis is logarithmic. So it's almost 1 log difference of E. coli and Klebsiella in IBS as compared to healthy. Now, deep sequencing has been published. This is in the Scandinavian Journal of Gastroenterology just this year, showing that IBS patients have a lower diversity and a higher amount of bacteria, again suggesting E. coli, Klebsiella, and another bug I'll show you in a second. This is normal small bowel flora, very diverse, a lot of different bacteria. This is what IBS looked like, and in this population that we did this deep sequencing, Eromonas was excessive, E. coli was excessive, and although you can't see it, Klebsiella was excessive compared to healthy. All of this microbial idea that the microbes of the small bowel are excessive in IBS, causing the gas and fermentation when people ate, led to the idea that maybe antibiotics could help. But what antibiotic would we select? Because we don't want bacterial resistance. We don't want to cause changes in the colon microflora. And so the premier candidate became rifaximin very quickly because it doesn't create bacterial resistance and it doesn't affect colon flora. And I'll speak a little bit more to that as we go along. This is the Target 1 and 2 trials that were proposed to the FDA for approval for rifaximin. And there were 2 trials, but they were identical, and you can combine the data. So the third line here is the combined data set. This line represents statistical significance. So anything that falls on this side of the line is statistically significant. And you can see that the primary endpoint, the secondary endpoint of bloating, other endpoints including abdominal pain and stool consistency, all were improved as a result of rifaximin in Target 1 and Target 2 and combining them. But not only that, if you look at this slide, the next slide will look identical, except at the top it will say 3 months. Again, 3 months later, the patients remained improved as a result of a therapy that was given for 14 days. So rifaximin suggested that there was an impact on the cause of IBS and that it had a response that lasted for at least 3 months. Now, the FDA initially said, well, if it only lasts 3 months, but maybe it will come back. If it comes back, we have to know, well, can you treat it again? So the FDA demanded a retreatment study. Now, the retreatment study has been finished. I'll show you this in a second. And now the FDA has approved rifaximin for IBS in the United States as of 3 months ago. The retreatment study cannot be compared to Target 1 and 2. This is not a primary efficacy study. Those were done. That's target 1 and 2. This was designed purely to assess if retreatment in a double-blind fashion would work. But because of that, and this design was in collaboration with the FDA said, we want this design. Now, this design is extremely difficult to succeed because I will show you the steps. First, you have to take rifaximin. You have to improve on rifaximin. If you improve, you stay in the study for 18 weeks. So if you are cured of your IBS, and 18 weeks later you're still well, you're out, finished. You didn't relapse. Only the patients who relapse then go on to double-blind treatment, and they get rifaximin, and then they get it another time about 10 weeks later. And the patients who get placebo will get placebo again. Now, this is what happened, and this is why this study was so hard to succeed because of the design. Here you have 1,074 people who responded to rifaximin. 1/3 of those patients never relapsed during the entire trial. They were fixed. Their IBS was fixed. They don't go on to double-blind, so your best soccer players are off the field. The patients who relapse are the ones who go to double-blind. So that's the first problem. The first problem is you take the less quality patients into double-blind. And I'll show you the next problem in a minute. This is the primary efficacy, the first double-blind section. And you say, well, there's a statistical difference. So the IBS patients who got rifaximin got better. But the delta is somewhat small. So the other problem with the trial is, I want to show you this. This is the starting severity. They were very sick to begin with. After rifaximin, some patients relapsed. But you'll notice they never got as sick as the beginning. So now, the rifaximin has only this much to work, not this much. So this is the second difficulty that rifaximin to succeed had. So you had the second-class patients, and you had already patients, even with relapse, who were never as sick as the beginning. And still, the rifaximin was significantly improved, and significantly improved the third time versus placebo. So the FDA approved this drug. On the constipation side, we now know that microbiome is playing a very important role here too, because methane or methanogens in the intestine slow transit down. This is a meta-analysis showing this effect, that methane, when present on the breath, is associated with constipation. When you infuse methane into an animal that's a live model of an animal, you get almost 70% slowing of the intestinal transit. So we know methane is slowing the intestine down. But what if you get rid of the methane? What if you get rid of these methane bugs? Well, what bug is it? So we now know it's Methanobrevibacter smithii. I could spend 1 hour just lecturing on this organism and how it causes constipation, but we don't have much time today. But what I can tell you is we've completed a retrospective chart review treating methane specifically. And for methane, rifaximin doesn't work very well. For methane, neomycin doesn't work very well. But for some reason, the two antibiotics in vitro and in this clinical retrospective review are synergistic in terms of getting rid of this organism and getting rid of methane and improving constipation. So we did a double-blind randomized control trial now published 1 year ago, giving neomycin plus placebo in a methane-positive constipation patients and neomycin and rifaximin. And you can see neomycin and rifaximin were better than neomycin alone in terms of constipation severity, bloating. But the most important factor of this study was if the methane was made to be less than 3 on the breath of the patient, that's the patient who had the best result in terms of constipation. So rifaximin and neomycin for methane, and for hydrogen, it's just rifaximin alone. And this is what we do now in our center. If they're hydrogen on the breath test, it's rifaximin. If they're methane, it's rifaximin plus neomycin, and then we reevaluate. The second part is, why does this happen? How does this occur? In parallel to the bacterial overgrowth theory being developed, there's been a theory that food poisoning causes IBS, or a gastroenteritis causes IBS. This is a meta-analysis that shows that if 100 people get gastroenteritis, 9.8 or 10% of patients will now have IBS, and many of them will have it forever or indefinitely. So how does this occur, and does this relate to the gut microbiome or to bacterial overgrowth? But the other problem is people say, well, but how much of IBS is bacterial overgrowth, or how much of IBS was caused by food poisoning to begin with? So I had IBS for 20 years. Do I remember 20 years ago 2 days of diarrhea on a trip? Maybe I remember, maybe I don't remember. So we took all of the data that was available on post-infectious irritable bowel syndrome, the follow-up data from 2 studies, 6 years and 8 years, looking at the cure rate, because some patients resolve and become normal again. And we said, well, if you put 300 million people into the United States today that are completely healthy in the normal age distribution, and using the Center for Disease Control data from Atlanta on food poisoning in the United States, how much IBS would be created just from gastroenteritis? And the answer is 9.1% of the entire United States would have IBS in 20 years, just from gastroenteritis as a single cause. It's a mathematical model. There are assumptions, so there's some possibility of errors, but it's very provocative to think that a lot of IBS could be from food poisoning. But we then started to say, well, if food poisoning causes IBS, and we know bacterial overgrowth is present in IBS, does food poisoning cause bacterial overgrowth? So we did an animal study where we infected rats with Campylobacter jejuni and another group of rats with just placebo, and followed them for 3 months after the infection cleared. And then we dissected the bowel to look for bacterial overgrowth by PCR. And what we found was that 27% of the rats who had received Campylobacter now have bacterial overgrowth. No more Campylobacter, it's gone. You can't find it anywhere in the intestine, but they now have E. coli, Klebsiella, and other bacteria building up in the small intestine, just like humans. In addition, the rats with Campylobacter and bacterial overgrowth, 85% of them had altered bowel form, so stool was soft. And they had increased rectal lymphocytes, which is the only finding ever found in IBS humans from food poisoning. So the acute gastroenteritis or post-infectious IBS, the only finding is increased rectal lymphocytes. So this is the first animal model of post-infectious IBS using an infection that is common to humans. There are parasite models and other models, but Campylobacter is the most common cause of post-infectious IBS. So we said, well, if it causes bacterial overgrowth, and we know that motility or slow motility can lead to stasis and then bacterial overgrowth, maybe there's a change in the neuromuscular anatomy of the gut. And the most important cells for the creation of migrating motor complexes, which are important for sterility and maintaining the ecology of the small intestine, let's study those cells. And the deep muscular plexus, interstitial cells of Cajal, cause the migrating motor complex. So we studied these, and we found that in the rats who received Campylobacter, who now have bacterial overgrowth, had the lowest number of ICC cells at all levels, but statistically in the ileum and the jejunum they were reduced. These are the pictures. I know it's hard to see on the big screen, so I put arrows. This is normal distribution of DMP ICCs, and they're stained brown using the C-kit stain. In the Campylobacter infected, but no overgrowth, the cells are still visible, but they're further apart. And the rats with bacterial overgrowth, the cells are very difficult to identify and very far apart, almost not connected. So why does this happen? How does this happen? And the other question was, how comes Campylobacter, E. coli, Salmonella, and Shigella, all of these bacteria, can cause IBS? So we're studying Campylobacter, but all the other organisms also can cause IBS. So there was a search we did for toxins that are produced by all of these 4 bacteria. And it turns out only one toxin is common to all of them, and that's CDTB toxin, cytolethal distending toxin. A is important for cell entry, C is important, or is unknown function, I should say, and B is the functional toxin. So it's the toxin that damages the cell, or at least in vitro. So we said, well, let's create a Campylobacter where we delete the toxin. So we infected rats in the middle here with a CDTB negative Campylobacter. So we deleted the toxin genetically. This is the regular Campylobacter. And we also said, well, what if you take rifaximin every day and you eat food with Campylobacter in it? Could you prevent IBS? And the answer is rifaximin prevents IBS in the rats. But CDTB, if it's missing, also mitigates the development of IBS in the rats. So we knew CDTB must be very important for the development of post-infectious IBS. So we developed antibodies to CDTB and said, well, let's infect the rats with Campylobacter today, and 4 days from now, let's see where that toxin is going. So we developed antibodies to CDTB and stained the tissue. This is the control stain, and this is the rabbit serum that has the anti-CDTB antibodies in it. And you can see that right away it goes to the ganglia, to the ICC cells. And if you blow this up, magnify the image, it's the entire enteric nervous system that the antibody to CDTB is attracted to. But this picture is exactly the same in the rat who had Campylobacter 4 days ago and the rat who never had Campylobacter. So we were confused, because why would a rat who never saw Campylobacter test positive, or the antibodies be attracted to the nerves? This concept is called molecular mimicry. So the toxin is making you form an antibody in your bloodstream on purpose, that this toxin has a similarity to a protein in the nerves of the gut, creating an autoantibody to your own enteric nervous system. But it took us 2 years to figure out what nerve protein was being attacked. So we had to get stem cells from Emory University and then do immunoprecipitation with the anti-CDTB antibody, and we pulled down one protein from the enteric neurons, and that's called vinculin. We also stained human tissue, and this is human ganglia, showing the antibody to CDTB binds to human ganglia in close proximity to the neural staining, and they co-localize. But this is the protein that the anti-CDTB is binding to, which is called vinculin. Another picture of vinculin is here. So these are cells that are reaching out to each other. If you look here, the red arrow is pointing to this red, like needles. That's vinculin protein stretching the tissue of the cell or membrane of the cell to reach to the next cell to attach. If you don't have vinculin, cells do not migrate, and the mouse model of vinculin knockout has no enteric nervous system because the enteric nerves never migrate, never attach to each other. So vinculin is very important for ICC cells to attach and the enteric nervous system to be intact.